Hi there, welcome back to another edition of About Everything with Neil Howe. I'm joined by Neil here in studio. Thanks, Neil, for joining us. We're going to talk today about his latest piece, which is up on Hedgeye.com, which is called The Surge in Mental Health Services, which is a subtitle, I love it. It's The Doctors In, Treating America's Mental Health Epidemic. Neil, what's going on here?
Well, this is quite a story. It's an industry that is growing very fast. It's really, we're talking about mental health services, MHS. Since 2003, national spending on MHS has nearly doubled. It's reached about 230 billion, and expected to reach 230 billion in 2016, and it's far outpacing GDP. It's almost as fast as the rest of healthcare spending. So you're dealing with a small part of total health spending, maybe about 7 or 8% of total health spending is mental health services. But for the first time now, it's actually keeping up with, or in some years actually exceeding the pace of the rest of healthcare spending. So this is kind of amazing, particularly since this is not high-tech medicine, right? These are mostly vintage pharmaceuticals, a lot of time spent with patients. So we're not talking about service intensity. We're talking about the growth through volume.
Sure.
Huge numbers of people being treated, and I think that's the big story here.
Can I ask you a quick question before we go on? So, you talk about the doubling since 2003. Right. That's huge, enormous. Is that a function of more mentally ill people, developing in society, or more mentally ill people actually getting help?
Almost entirely the latter. This what you call out of the woodwork phenomenon, and we can talk a little bit about that. But historically, the way we have dealt with mental health spending is by forcibly constricting the demand. Okay. We don't cover it. Historically, we have not covered it. Much higher cost sharing in private insurance than somatic health, the kind of physical problems, as well as something we'll talk about in just a second, which is restrictions on the use of Medicaid dollars. State hospitals used to cover and hospitalize the extreme, those who are moderately to severely mentally ill. Medicaid dollars were not allowed to pay for it, and that was part of the original design of Medicaid, because they did not want, the federal government did not want to displace state spending on its own institutions, its asylums basically. Right. This is now beginning to break down, actually, and legislation is being considered this year, and it may actually go into effect, new regulations as well as legislation in 2017. Right. So we're going to talk a little bit about that. But what I mean to say is that this is an industry. Only a few companies specialize in it, and it is the profit margins are remaining very high even as the volume expands. Two big players here who who dominate this is Acadia Healthcare, which is the largest network of inpatient and outpatient treatment centers, and also UHS, Universal Health Services, and even HCA Holdings, the enormous hospital service provider company, says that behavioral health business is one of its fastest growing parts of its business. You have the American Addiction Centers has been on a buying spree. So basically, the point is that this is the stock prices of these companies have been on a tear, and there's a lot of spending going on physical infrastructure. For the first time, these companies are actually building inpatient hospitals to deal with the breakdown of this IMD restrictions. So even the number of eating disorder facilities has more than tripled in the last decade. So a lot of movement going on here, a lot of growth, a lot of opportunity in what's a pretty small channel for existing infrastructure and expertise in this area.
What's driving all this? Why is this happening? What's going on?
Well, a couple things. I would say one big turning point was the 2008 Mental Health Parity and Addiction Equity Act. And parity among mental health providers and activists who are in this field has been the big goal, and they finally achieved it in 2008. And that was basically to say that if you offer private health insurance, you have to cover mental health treatment on the same basis with the same cost sharing as all of your other somatic care, right? Well, that was big because that was one of the ways we dampen demand for mental health, we didn't really cover it very well. Very large cost sharing, often very low caps on lifetime use and all that stuff. That was the first thing. And the second thing was the ACA, Obamacare. One of its provisions was, okay, if you have private insurance that covers mental health, it has to be on the same basis of any other kind of health. The ACA said, if you have private insurance, you have to cover mental health.
Wow. Yeah.
So that was that completed it, right? And also, ACA also, for the first time, set up minimum requirements for state Medicaid plans. So now there is actually a standard that states have to follow. Particularly Medicaid has been very important in the states at in community care, outpatient care, and so on. And so now Medicaid basically is the same kind of parity is true for Medicaid coverage. What this has meant is that all of the people who used to not get care are now have access to care. That's why I'm saying this is being driven by volume, not intensity. I come back to that. Anyway, so I would say that's number one. Medicaid and Medicare in particular are very important. We have a chart here somewhere on payers, who pays for this care. You see the big decline is state and local institutions, and we'll talk about that just in a second. It's kind of the deinstitutionalizing of healthcare in America. And you see the big gainers are Medicare and Medicaid. And particularly Medicaid, growing more. The second big driver is, you asked, are more people getting mentally ill, or are we just treating the ones that are?
Right.
Okay, we've dealt with the second one, right? There's also a lot of evidence that there are more people manifesting emotional health problems. This is a long finding of epidemiologists that the incidence of mental illness increases by cohort for every cohort born after World War II. So basically, starting with boomers, every passing birth year, we have seen in each cohort a higher incidence of mental illness and beginning to manifest itself at an earlier age.
That's unbelievable.
Whether you're looking at depression, you're looking at OCD, you're looking at bipolar, whatever you're looking at.
And you don't think that there's any chance that these things weren't hidden, that they weren't just getting acknowledged, they weren't being,
A great question, and it's virtually unanswerable.
Yeah.
One of the things that anyone knows as a boomer is that parents never talked about emotional illness. I don't know if you remember Eagleton, who ran as the vice president for McGovern.
Who cried?
No, that was Muskie.
Muskie.
That was Muskie who cried. There was another guy who was running for president. But Eagleton actually had treatment in a mental health facility. He might have even had electroconvulsive therapy.
I mean, he gets it disqualified.
Well, it was a scandal.
Yeah.
You didn't talk about that stuff.
Right.
And one of the reasons you didn't want to show, any kind of emotional problems, you didn't want to get locked up in an asylum, which is what we used to do back in those days. Anyway, it's a combination of both. One thing you're familiar with is boomers, and particularly Xers. I mean, they'll go on whining on Oprah, about everything that's wrong with them, and I was listening to Glenn Beck the other day, and my God, there's a boomer who's just all out there, about how he's a throwaway child and all the things that happened to him and all the things he had to cope. Well, this is new, so this willingness to talk about it is also new. Which, right? It's kind of hard to say. Is it that people always had it, they're willing to talk about it? But one thing is clear, we do talk about it today, and we do want treatment today. And we want treatment not for ourselves, but for our loved ones, for our family members. And I would say at the leading edge of this is kind of a third driver, is boomers, because boomers are at the leading edge of this increased both demonstrativeness and incidence of mental illness. And you can see a lot of this is tied up in a lot of the history of boomers' kind of notoriously unhealthy lifestyles. It's left and burdened them with higher rates of chronic diseases and disabilities into their 60s and 70s. And a lot of these disabilities, particularly with regard to addiction, are comorbid with mental illness. These people are more likely to have depression, or even more likely to manifest a lot of these things. So substance abuse. Take a look at opioid addiction, which is a scourge now among boomers and first wave Xers as they move into their 50s and 60s. And we can see this. I think we actually have a chart here, which is rather interesting, on the prevalence of cost of individuals with major depressive disorder. And what's interesting here is you see that both the population with MDD, major depressive disorder, is going up But you see particularly large among the elderly, as well as the total direct cost of treatment,
Right.
and among the young. And that's another thing. That's kind of the final driver, and that is millennials. Now, here's the interesting thing about millennials. You think about young people, say, in their teens and 20s today, early 30s. By most objective measures, if you look at suicide rates, alcoholism, and so on, this generation is actually doing pretty well. Suicide rates are actually less than they were for Gen Xers in the 90s. But they are so willing to talk to credentialed older people about their problems, right? They trust older people to help them and solve things for them. This is a generation that's very willing to open up to counselors and inviting them into their lives to help them solve their problems, much to the disgust of many Xers, like yourself, I'm sure. What's the matter with these kids?
It sounds like a good thing, the suicide rate's going down.
Yeah, it is going down, but that means a huge demand.
Yeah.
In other words, they may be actually doing okay when it comes to very severe crisis situations, but they really have an enormous demand. I've seen this, I've been in countless universities and colleges, and everyone tells me, not necessarily for severe things, but just ordinary things. This generation is so much more dependent on counselors and help and therapy, just older people helping them out.
So before we head on to the next topic, we're going to talk about the broader implications that are going on here. Is it fair to say, it sounds to me like you're suggesting that there's almost like a Leave It to Beaver 1950s culture where you don't show pain, you don't, so people were probably self-medicating with a bottle of rum or whatever. Now they're actually going to see counselors. They're going to seek help. They're going to see professionals.
Yes.
And there's money to be made with these companies that are dramatically outpacing the S&P 500, et cetera.
Well, it's the combination of the fact that you always had a huge number of people who needed treatment and weren't getting it. Yeah. Plus the fact that we're much more open about it. So even if in the old days you didn't know you needed treatment, now you do.
Do you know offhand what the suicide rate, for boomer age type people were a generation ago?
It's growing.
It's growing.
Oh, it's higher. Yeah. So there we have objective evidence. Interestingly, boomers in every age bracket they've moved into have kind of pushed up the suicide rate. Okay. So suicide rate went up and was quite high in the late 60s and 70s among teenagers. Now it's actually gone down, but it's gone up for midlife and people entering their 60s.
So broader implications.
One is, and I just want to get out of the way first, and that is the advent of, although I said there's a low-tech industry, we're beginning to bear new technologies of actually beginning to, and this is just in its infancy now, but looking at someone who has a mental illness problem and being able to test their blood to actually go in and look at chemical markers. What this does is that one of the problems with treatment of mental illness is that there's a lot of talk about the placebo effect, and even with drugs and drug therapies, how often the effect isn't much better than a placebo. I'm sure you've heard with Prozac and a lot of these SSRI or SSNI drugs. They're not all that effective necessarily when you do a double-blind test. But I think now with the ability to actually use objective measures of chemical markers to actually say, no, you have bipolar, you have depression, you have OCD, whatever it is, we can actually test for that. This marks a breakthrough. And I think that actually could legitimize further spending or a little bit more high tech in what's been a pretty low tech.
Are there public companies in that space that you're aware of? Or are they probably
no, right now they're independent. I'm sure as soon as they get close, they could all get bought up by the publicly traded companies. The other end, this is a big trend. This is very historical, very generational, and that's deinstitutionalization. So you cannot understand mental health spending in America unless you understand the whole history of deinstitutionalization. In the 1950s, we institutionalized very regularly. And you have to remember that this was considered a good thing. Back in the 1900s, insane people, what we called them insane was the word we used, were often ended up in jails and prisons. Well, Dorothea Dix, a number of the great reformers of the 19th century, crusaded to get these people out of prison and into insane asylums for the insane, they called them. And this was considered a great progressive movement, where they got the care they needed. Well, by the late 50s, we had over 500,000 Americans in these state-run asylums. And suddenly, there was this big furor about how badly they were being treated. And I'm sure we all remember Ken Kesey's novel One Flew Over the Cuckoo's Nest with Nurse Ratched,
in the movie,
Jack Nicholson, playing, right?
Right.
So there was this horror, and actually it was John Kennedy. The last piece of legislation he signed before his assassination, actually, was a mental health deinstitutionalization act, which basically this generation said this was a bad idea. We need to get these people out of these asylums, out into the community, where the states would then arrange community-funded treatment.
Okay.
It's okay. What happened? Well, the states were glad to get rid of these people, right? They didn't have to pay for them anymore, and there was a big ideology around it in the '60s and so on. Get those people out of these institutions. Right. But we didn't really pay for any community-oriented treatment, and furthermore, these people were often very sick. They didn't necessarily take their meds. If they weren't being supervised, they ended up, as many people said, they went straight from straight jacket to steam grate. You know what I mean? They were in the streets. They were in and out of homeless shelters, right, which is where we find them today. Right. Today, only 60,000 people are institutionalized in state facilities, down from 500,000. We have a population that's almost twice as large.
I was going to say, what was the population in the 50s versus,
Exactly. Yeah. It's about doubled since then. So here's the interesting thing.
Yeah.
Where are these people now? Back in the jails, back in the prisons. They're approximately a third of all prisoners and people in prison, particularly in jails, are considered mentally ill. In fact, a lot of you consider the 1/3. The large 1 out of 3 have some degree of mental illness. Right. The largest facilities that take care of the mentally ill today are America's largest county prisons. I'm talking about LA, Miami-Dade, Cook County. These are the people who, and they have special treatment centers. A lot of these jails are now building special wings. So ironically, right, they're back in the jails where originally we took them out, or they're out on the streets. And I think there's a big movement in this country that basically says this is not cost effective, this doesn't work. And I think the next thing we're doing is that we're weakening. I think I told you earlier that one of the original provisions of Medicaid was called the IMD, which was the IMD exclusion, which IMD basically means Institution for Mental Disease, which basically Medicaid would not be able to pay for any of these dollars for institutionalized care. Right. There is now a couple of pieces of legislation. A lot of people think this will go into effect next year, which is the first time Medicaid dollars will be able to pay for private contractors who actually specialize in psychiatric or behavioral therapy to actually take care of these people. This is a big new business for exactly the companies that are already growing very rapidly.
Yeah, there's something on a related note that jumped out at me in your piece that's on our website right now, hedgeye.com, which you wrote, most U.S. counties don't have a single psychologist, psychiatrist, or social worker. That I highlighted that. It jumped out at me. It's a huge, huge growth opportunity, right?
It's huge, and again, it comes back to the way it's a little bit like on nursing homes. There are certain areas of care which we historically. The way we've suppressed demand and made healthcare affordable. Ironically, of course, healthcare is hardly affordable in America. We pay more for it than any other country in the world. But one of the ways that we've stemmed demand is by making it very hard to get care. And I think mental illness was always one of those areas where we basically said, the only way you're going to make this affordable is just make it difficult for anyone to get. And there is an issue here, because let's face it, what do people come to a mental illness practitioner for? Sometimes it's for truly severe mental disease, where everyone acknowledges they have to have some sort of supervision and treatment. Other times it's more for just to be more socially integrated. Other times it's just personal development, right?
Sure.
If you let everyone go, I don't know, we all might go, once a week, to see someone to. So it becomes, there's a big moral hazard issue here. And I think policymakers have always understood that about mental illness. I think now, however, we've reached the point where, and this is my final driver here, that Americans may feel it's cheaper to serve this demand to ignore it. And I have a chart here which is increasingly, I think,
social cost of mental illness.
Exactly, social cost of mental illness. And if you compare the direct cost of treating the mentally ill with, the cost of suicide, addiction.
You wrote, for every dollar spent on major depressive disorder, in 2010, almost $7 was spent on the effects of untreated depression. depression.
I mean, this is particularly true with regard to addiction. And we all know that with regard to opioid addiction, for instance. Untreated, the problems that occur. And as you were pointing out before the show, Dan, and I think it's worth saying, in this respect, the mental health services is trying to clean up what the rest of the health services started with regard to opioid addiction. They're the ones prescribing all the opioids, right? And now we have this MHS, which is trying to clean up after what the rest of the system
It's almost a non-virtuous cycle in a way.
So that absolutely is a mess. So the interesting thing is that AMA now supports this. There's a huge culture war going on among particularly boomers, older healthcare practitioners in the mental health space. And the culture war is between those who do not forget the 50s and 60s and 70s and want to keep deinstitutionalization. Their complaint is community-based care works. You know, we just never really tried it. We never really funded it. So they're very much opposed to this reinstitutionalization, basically funding actual, institutionalized care provided by private companies. And the other group which says, no, institutionalization never worked. These people need supervision. They need care. They can't stay on their meds. Families are going crazy often when they have a young man, young woman who sometimes is violent. You can't do anything. You can't call the social worker. You can't do anything. You can't call the police. They won't do anything, right? And I think particularly with the rise of mass murders, which recently in the news, from Sandy Hook and all the others that we remember, there's an increasing awareness that this is an issue that really does have severe social costs, and a lot of it is the downside of deinstitutionalizing this, which has come back to haunt us, right? We thought we were doing a good thing. We thought we had another mode of treatment, but maybe it didn't really work out.
So we're going back, and
we're going. I think that's the future, and we are going back.
The asylums are coming back.
Well, we're not obviously. No one today is going to call them an asylum.
That, treatment center.
But these are treatment centers, and these are more hands-on, inpatient treatment centers where people who cannot control their own lives, for instance, at the very basic level, just staying on your meds is probably one of the biggest things. If you can't stay on your medication, you really probably shouldn't be out in the community, and so someone needs to be taking care of you. And I will say in this regard that profit margins stay high in this industry, even as it expands, because we've changed the professional responsibilities. Today, you only pay the doctor to do the meds, right? So they do the prescriptions. They maybe have 15-minute visits. They get paid more than psychiatrists used to do. Psychiatry used to be one of the least paid medical specialties, back in the 60s and 70s. All they did was these long talk sessions. You can imagine how much that paid them. Today, they get paid more. They focus totally on the medications. And meanwhile, all the talking and behavioral therapy is done by PAs, RNs, barely credentialed social workers. And this actually is an efficient mix, right? You take a lot of people who actually have some of these people skills. They follow certain protocols. They get the job done. But you can imagine, even at affordable rates, this provides a pretty good profit margin for the company.
On a related note, we, as you're obviously well aware, our healthcare team, spearheaded by Tom Tobin, has a really interesting thesis, talking about the ACA taper, which is basically the massive front loading of, of healthcare usage. And, is that even a factor here? I
don't think it's a factor here. One thing you have to remember with the ACA taper, you did have a lot of people coming into the system for the first time. They had a lot of chronic problems and even, just
like a hip replacement, and then it's done, one and done, and you're out.
It's one and done, you're out. You had a surge and stuff, but then it's over. That's not the case here.
This is ongoing.
This is the case of ongoing. We don't yet have cures for this.
What a couple more questions before we wrap it up here. What would you say? 10,000-foot aerial view. What are the big implications going forward for investors? If you read about the return back towards these treatment centers. What are the biggest implications for investors right now?
I would just say, given where we're moving with the 2008 Act and with ACA and the parity for Medicaid, and increasingly, particularly with the erosion of the IMD exclusion, which is likely to occur next year, all of this fires the furnace of growth.
Right.
And I mentioned two companies in the news, and one's Acadia, the other is Universal Health Services. I think Acadia maybe, I would just say from a balance sheet and earnings perspective, Acadia may be a little dicier, a little riskier for some people looking into it. I'd say UHS is a safer bet. Medicare is being driven by two things. One is as we talked about, boomers. Obviously, past age 65, they're on Medicare, and so they're turning to mental health services increasingly. And the other big driver is all of the boomers who retire early on disability insurance. So even if you go on DI at say 53, you get Medicare. Okay, so Medicare is one of those entitlements that comes along with your DI. Right. So that's another big, and a lot of the people actually. There's another indicator. Emotional illness as a cause of disability is a growing share of DI, as opposed to a back problem or something like that.
Right. Well, there's a ton of really granular, information in the piece on the website on hedgeye.com. It's the surge in mental health services. It's the latest in Neil Howe's About Everything series. You can also follow Neil, don't forget, on Twitter at HoweGeneration. And we look forward to seeing you next time. Thanks so much for joining us today.